Yvonne, for the reintroduction. As you've already heard this morning, international collaboration has always been part of the mission of the observatory right from the outset, as it is obviously today. We know and we recognize that we are stronger together than being separate. That's why we're so delighted that we have got this collaboration with the Center for Disease Control and Prevention in the US, and to have that collaboration formed, which was on the back of the G7 summit last year in Cornwall, has been absolutely fantastic about that. But we'll speak more about that partnership in a moment. But I wanted to begin by talking about why we formed this particular partnership in the first place. This is a quote from the observatory's most impactful report over the last year. It's our rapid evidence review, and it's a quote by Dr. Dharmi Kapadia from the University of Manchester. And I wanted to start with this because it's a statement that demands a moment of closer consideration. Ethnic inequalities in health outcomes are evident at every stage throughout the life course, from birth to death. And we've heard that this morning as well. It's a shocking statement in itself, not just because it's true here in England, but it's also true in some of the world's richest and most powerful countries. As you see throughout the conference, it is so often these apparently progressive countries who have historically failed to eradicate these inequalities, which is why this partnership with the Center for Disease Control and Prevention is so important. In December 2021, the observatory signed a memorandum of understanding with the CDC, and this memorandum of understanding enables us to do a number of things, three in particular. Firstly, to share learning. Secondly, to pool our resources together. And thirdly, to collaborate on projects drawing on the strengths of both organizations. In deciding where our partnership should start, the answer seemed obvious. In both nations, here in the UK and in the US, we have been busy battling COVID-19. And in both nations, we have been digesting the sometimes difficult questions and lessons that we have learned from the pandemic. Just to put this into context, just a couple of slides around data. The pandemic, as we've heard, exposed in our nations the deep-seated ethnic inequalities that had existed for some time. In the UK, we saw very quickly that many Black, Asian, and other minority ethnic communities in this country were dying from the disease at a higher rate than the white British population. Although this varied from wave to wave of the pandemic, this graph is a stark illustration of the inequity that we have been seeing in COVID deaths. The white group, which is shown in yellow here, shows that 126 of the 100,000 population died from COVID-19, compared to what you can obviously see, the higher bars, the Bangladeshi group at 349 from 100,000, and the Pakistani group 289. And these differences are in some cases even more stark for males. And this bar chart shows exactly that. In this graph, the white British group has an average age standardized mortality rate of 202 per 100,000. Bangladeshi men, the figure is more than 3 times higher at 720. Of course, there are large differences between groups as well, which we should, and of course, keep in mind as we move forward. Vaccines is another area to do with COVID that we've been particularly focused on. And in terms of vaccine uptake, we have seen disparities. As this graph shows, for white British, Chinese, and Indian groups, the percentage of people who have had 3 vaccinations in this country is around 75%. At the other end of the spectrum, however, the lowest proportions of people were Black Caribbean at 38%, Black African at 45%, and Pakistani at 45%. These are some of the disparities that we are familiar with. And as our colleagues from the CDC will go on to discuss, there are similarities in these data. And our panel will explore those similarities and some of the underlying issues associated with the patterns of data that we see both in the UK and in the US, including, of course, the issue of trust and the notion that trust is fast becoming a social determinant of health. We want our partnership to explore not just the factors that drove those inequalities, but also the lessons that we can take forward. And so before I hand over to my counterparts, I wanted to end with yet another quote, this time from the American author James Baldwin. And you may have come across this, I'm sure you've come across this quote before: not everything that is faced can be changed, but nothing can be changed until it is faced. And in the spirit of continued working with our colleagues, I'd like to hand over now to Leandris for her keynote.
Thank you, Dr. Naqvi, and good afternoon, everyone. We are honored to be able to partner with the Race and Health Observatory in the pursuit to eliminate health inequalities and achieve racial equity. And on behalf of my colleagues who were unable to join us in person, Dr. Becky Bunnell and Dr. Robbie Goldstein, we are thrilled to share what CDC is doing to elevate our efforts to achieve health equity. And so before you hear from Locola Hayes, who will detail CDC's commitment to equity, I will begin with our COVID-19 experience. Am I advancing? All right, so next slide, please. So the CDC COVID-19 response health equity strategy was developed under the leadership of the Chief Health Equity Officer, and I was privileged to be the agency's inaugural Chief Health Equity Officer. And we created this strategy to afford a robust platform from which CDC and its partners could pursue deeper engagements with diverse communities, to create stronger infrastructures to better support data-driven action, and to increase culturally responsive approaches optimized for serving diverse, differentially impacted populations in different areas across the country. We understood that COVID-19 could exacerbate already existing health and social inequities, and it did. And data highlighted groups, and this is at the beginning of the pandemic, at increased risk of COVID-19 that included racial and ethnic minority populations, people experiencing homelessness and substance use disorder, persons with disabilities, and people who were incarcerated or otherwise detained, as well as persons born in other countries. We also saw health disparities among people living in rural and frontier communities. And in addition, we worked to respond to the reality that racial, ethnic, and other minority populations at higher risk for COVID-19 face unique circumstances, and that effective public health intervention planning must account for the particularities of the populations in order to increase our chances for success. Next slide, please. So I want to quickly share some of the data about the impact of COVID on communities of color. And I think what I want you to just pay attention to are the different colors, the peaks. So the blue, AIAN, is American Indian, Alaska Native, and then Native Hawaiians. We also have data for Asian and Pacific Islander. I'm sorry, let me back up. It's American Indian, Alaska Native, non-Hispanic, which is what NH is for. We also have data for non-Hispanic, Asian American, and Pacific Islander, non-Hispanic Blacks, Hispanic, and non-Hispanic whites. And so the U.S. Reached greater than 1 million cases over the course of the pandemic. And as you can see, if you look at the legends, that Hispanic, which are in the yellow bar, American Indian and Alaska Native, which is the blue bar, and Black populations, which are a light gray, were hit hardest. Next slide, please. So Hispanics, again, same legend. Hispanics and Latinos, American Indians, Alaska Natives, and Blacks experienced the highest death rates across variants and surges. Next slide, please. And then based on vaccine administered data of adults, you can see that across all racial and ethnic groups that there is less than optimal vaccination coverage in the U.S. And so we are continuing to try to increase that coverage, working with a number of national organizations and other trusted partners. Next slide, please. So just to give you a quick glance at the actual COVID health equity strategy, as we learned more about the impact of COVID on the health of different populations, we adopted a set of guiding principles. And those included to reduce health disparities, to use data-driven approaches, to foster meaningful engagement with community institutions and diverse leaders, to lead culturally responsive outreach programs, and then to reduce stigma, including stigma associated with race and ethnicity. We created a plan with 4 strategic priorities, and these are not necessarily listed in order. So priority 1 was to expand the evidence base with data to inform the impact and factors that influence the burden of COVID-19 on disproportionately affected populations. And we were able to observe and document the impact of occupation, the inability of certain occupation groups to protect themselves from public exposure, and other kind of non-clinical things, if you will, that were actually driving this disproportionate burden. Priority 2, expand programs and practices to reach those populations that have been put at risk. And priority 3, which to expand program and practice activities to support essential and frontline workers to prevent the transmission of COVID-19. And so we had categories of workers who became essential during the pandemic. Groups like grocery store workers became essential, in addition to our healthcare workers. And then priority 4 was to expand an inclusive workforce equipped to assess and address the needs of an increasingly diverse U.S. population. I know we've heard a lot about that today, but it was really, I think, important at CDC to really elevate and recruit members of our CDC population who were diverse and who could speak to issues and challenges that others wouldn't be sensitive to. So next slide, please. I just want to summarize some of the lessons learned, and I know we'll get to talk more about this, but having come through COVID, and we continue to learn, we had to understand how differences in access affect communities. Also to develop and implement approaches to address those differences, and there have been a number of really innovative initiatives that have emerged. And to consider their impact on different groups. Like many of you, we had to move away from the one-size-fits-all perspective. And really importantly, as has been said many times today, we had to mobilize community engagement and support, as well as to identify inequitable conditions in the social environment. And we also understood that there was a necessity to change community dynamics to support health, and then to implement public health policies that address underlying causes of health inequities. And so this is clearly an ongoing process, but we can say that the COVID experience really swept us into a much more aggressive and comprehensive approach to addressing health equity. And so with that, I'd like to ask Locola to come up and describe our broader health equity agenda going forward.
So I'm charged with talking about the next steps for CDC and introducing our agency core health equity strategy. And we call this our science and invention strategy because underlying the work that we do as an agency is our science. So in the mix of COVID, we not only recognize that COVID was important and communities of color were experiencing disproportionate rates and numbers, but they were just being impacted differently. And so it illuminated the inequities and inequalities that existed in our society for generations and really revealed for all Americans an unspoken, unnamed epidemic in public health. And that's racism as a public health threat. In 2020, in the midst of COVID, we not only saw changes with COVID, but we also had a social justice movement happening in the U.S. And through this, we saw a number of executive orders identifying the need for advancing racial equity and supporting our underserved communities of color. We had memorandums issued releasing the need to combat racism and xenophobia and intolerance against populations, specifically Asian Americans and Pacific Islanders. There was also an executive order about expanding and ensuring equitable pandemic response across our communities. And CDC Director in 2001 announced officially, for the first time in history, racism as a public health threat in the U.S. On the heels of this, Dr. Liburd, myself, and our two colleagues in the Office of Science and the Office of the Director at CDC worked closely together to help stand up an agency strategy that we now affectionately call CORE. And I'm going to walk through each of the acronyms of CORE. The C is combating, okay, you guys can still see it, but I can't. Okay, I'll just use the slide deck from here. Okay. C is cultivating comprehensive health equity science. What is health equity science? Health equity science is science that investigates the underlying contributors to inequities and builds an evidence base that will guide action across the domains of programs, surveillance, policy, communication, scientific inquiry, and move us towards eliminating rather than documenting the inequities. So we want to move from just saying these are the markers, this is what the data shows us, to what's really driving that data, getting to understanding why we're seeing what we're seeing in that data. And when we think about the guiding principles of health equity, we're thinking about really how do we conduct science for action? How do we clarify what we mean when we use the terms race and ethnicity? Being explicit when we talk about the purpose, the methods, the interpretation of the results. Being intentional and including racism and talking about the particular structure of racism that exists. When we talk about our comprehensive science and health equity science, our overall agency strategy builds on 3 platforms: transforming our surveillance systems, building health equity data science capacity, and building an evidence base. Long term, we're looking to improve the quality of our science, improve the evidence base, and make sure that we have systems in place to really address the factors that contribute to health equity. I mentioned our work under scientific principles, but we are also working towards making sure that our data and surveillance systems are using standard language and that all of our national systems are measuring and talking about the definition of race and ethnicity in similar ways. Next is our O under core, which is optimizing our interventions. And the strategy here is to really build and scale interventions and programs. Important component of this is making sure that we not only scale and implement evidence-based policies, practice, and interventions that are truly going to address health equity. I'd like to highlight one of our major activities include a health equity glossary. So making sure all of our partners, all of our programs across CDC are speaking the same language when we talk about key terms. What is equity? What is health equity? How do we define inclusion, inclusivity? How do we define race? And next, we have our health intervention principles, which are a set of guiding principles that are foundational to our ability to create and sustain solutions that help to drive public health practice and implementation. As we move across to the R, this is really to reinforce and expand our robust partnerships. And when we talk about partnerships, we're talking about 3 levels: across the agency, with our federal partners, and then externally, like the partnership that we're building with RHO. And the goal here is to really identify where those systemic barriers are and to really come up with effective strategies for introducing and defining those. Through this bilateral partnership, we often use the quote, "Addressing health inequities is a global challenge that requires a sustained and collaborative and international response. We can't do it alone. The U.S. can't do it alone. We need partners across the board because it is a global pandemic." And then lastly, in the lane of E, this is where we look internal to our agency and across our public health practice to really enhance the capacity and workforce diversity, inclusion, and engagement. Our goal here is to really make sure that our workforce reflects the communities that we serve. We have agency efforts underway to make sure that our culture at CDC infuse diversity, inclusion, equity in all that we do. The overall goal of CORE is to really make sure that we're embedding health equity in the fabric of our agency and that we are being transformative in how we think about and how we approach health equity moving forward. So with that, I'll say thank you for allowing us to introduce our CORE strategy.
Thanks very much, Locola, and thanks to all of our speakers. My name's Sam Rodger. I'm the Policy and Strategy Lead at the Race and Health Observatory, and I've been helping broker this partnership as well, so I'll be leading the panel today. Just to reintroduce everyone before we get started, you've already heard several times today, in fact, from Dr. Habib Naqvi, the Director of the Race and Health Observatory. We also have Dr. Leandris Liburd, Associate Director for Minority Health and Health Equity at the CDC, and her colleague Locola Hayes, who's a management official within CDC's Office for Science and the CDC lead on our partnership. And also to welcome to the panel Professor James Nazroo. Professor James is the Professor of Sociology at the University of Manchester. He is co-chair of the Observatory's Academic Reference Group, a member of our board, and a member of our International Experts Group. Welcome, James. So part of the spirit of this partnership, as we've discussed already, is about learning lessons from each other and from the pandemic. And that's not just about looking back at the quite stark statistics we've already seen. It's about thinking about policy and practice. And I think we've all observed that in any public health crisis or a crisis of any kind, there is invention and nimbleness in the delivery of public service. And so as well as looking back on what went wrong, it's also our duty to look at what went well, what worked, and what we can replicate both for future health crises and the everyday delivery of care. So in that spirit, I'd like to ask the panel to reflect on lessons they've drawn from the pandemic. I'll start with James, as we've not heard from you yet.
Thank you very much, Sam, and thanks for giving me the opportunity to talk to this. It is a real pleasure to be here at this very important event and to learn from what happened during the COVID-19 pandemic as we go forward. I think I want to start off by saying thank you to Locola and Leandris about the insights you've just offered us, the kind of structured, thoughtful, comprehensive approach that CDC is taking in relation to this. We can all learn a great deal from that, I think, and begin to wonder about how and why we might set up such comprehensive systems here and elsewhere in the world. A really impressive program of work. And obviously then lessons learned, some of the things I'm going to say will echo some of the things that they've already said. I start off with surveillance and the need for data. And again, I'm echoing what other people have said, of course. Just to initially make the point that we didn't find out about ethnic inequalities in mortality rates from COVID from scientists, from public health, from statisticians, from ONS. We found out about this from grassroots activity and the media. The first systematic collection of evidence on this was done by the Guardian newspaper. The Guardian newspaper. And then subsequently, the public health movement began to address this question, and ONS began to develop data systems that would allow us to monitor this. Step back a bit. Before the pandemic, where were the surveillance systems for the health of the population in the United Kingdom? We have this fantastic survey called the Health Survey for England, which annually collects data on the health and health behaviours, including biological data of the population. The last time it sampled to a meaningful degree ethnic minority people was 2004. 2004. We came into the pandemic without any up-to-date information on the health of ethnic minority people in the UK. Why is this so important? It's so important because we need to identify the populations who might be vulnerable in a time of crisis. We need to have that information in advance so that we can put in place mechanisms to protect those who might be vulnerable. And I'll talk about that in a minute, but mechanisms that can protect those who might be vulnerable in a time of crisis. If we don't know who's vulnerable, then we can't do that. And so this notion of the pandemic being a great leveler, of course, we knew this was not true, but also we did not know which populations were necessarily particularly vulnerable because public health systems didn't have the data to identify that, or didn't have up-to-date data. Continuing with the surveillance, health surveillance point, is that even when we do have these systems in place, they don't cover all of the populations at risk. One thing we haven't talked about is the high rate of mortality of Jewish people during the COVID-19 pandemic. None of our health surveillance systems collect data on Jewish people, or Gypsies, Roma travellers, and so on. So there are some groups that are invisible to our data collection systems that we need to think about and address. Having said all that, I'll say again, the second lesson that we have learned is the need to protect the vulnerable at these times of crisis. And so we can think about that in terms of identifying groups who are vulnerable. We saw this in terms of people resident in care homes, and we saw this in terms of ethnic minority people. We did not put in place the necessary protections for those people. And then the third thing to say in relation to that is in terms of working with communities and with people to develop the systems that are necessary. So the systems are designed, led, and implemented by the communities who are affected, not in a top-down hierarchical way. And again, you talked about community partnership, which I think is such an important thing. Community leadership, in my view, is equally important. And then attached to that is the question of trust, which Habib raised, and indeed David talked about it in his talk, where trust is located, where we see failures of trust not being the responsibility who don't trust the systems around them, but the systems around them that engender inequality and consequent lack of trust. And so to rethink the ways in which working in partnerships with community builds trust and addresses questions of inequality. That's my starter for 10.
Fantastic. Thanks very much, James. I think in the spirit of international even-handedness, I'm going to jump to one of our US colleagues now. Leandris, do you want to speak next?
So, on? Okay. So just to echo and to certainly agree with what James shared, early on, one of the things that I know I encountered as the Chief Health Equity Officer was is how data was going to be reported, and there was going to be an instance, I should say, where non-Hispanic Black race was an independent risk factor for COVID, and just the representation of that was very troubling for me. And I said, we really can't talk about race in that sort of way that becomes almost purely biological, blaming and just in general not very helpful. And so we went through this process, and Locola mentioned our health equity glossary, where we discouraged the use of terms like vulnerable population. We said these are populations that have been made vulnerable. We discouraged the terms, marginalized groups. These are groups that have been marginalized, right? And so if you say I'm part of a marginalized group, I have no way out of that status. There's no amount of personal responsibility that I can take to not be marginalized because I've been categorized in this, particular way. And so our language, we had to grapple with that. And that was just a couple of examples. And we, created not only a glossary, but a resource called Health Equity Principles for Inclusive Communication, which, if you were ever interested, is on the CDC website. So those were, that's something that I think hasn't been mentioned, that was really important, I think, in our lessons learned. And while many of us have been doing the work of addressing health disparities for several decades now, and these were not new things for us. We were not caught off guard that communities of color were going to be disproportionately impacted. But we now had this opportunity to get the attention of the entire agency and our partners and the community, who also, this was not news to them because we were hearing from the community. Let me say the last thing. While we have, I think, strong data systems and established racial and ethnic categories, the ability to get data from our states and coming into CDC so that we could, aggregate it to kind of know what was going on around the country was very slow. So at the beginning, we had something like 23% completeness of like racial and ethnic data. We're now we're approaching, 70%, and depending on if you're looking at race and then ethnicity and then race and ethnicity together, the percentages are much better. But we have to be much more efficient in being able to capture this information, because people were observing people in African American communities, other communities of color, literally dying, but our data wasn't keeping up in real time with what was going on in the community.
Thanks very much, Leandris. An interesting tension seems to emerge, doesn't it, between making sure we have that data, making sure everything is quantified and tracked, but not allowing that process of quantification to lose sight of that human side of this, the fact that it's real people who are dying. I wonder now if I can come to you, Habib, for your reflections on lessons learned.
Thanks, Sam. And I think the data point is really important, and I think we observe that here as well in terms of having real-time data at local level and how critical that was in terms of particularly local public health departments' responses to that. But I want to focus on engagement, if I may, and just three very quick points. Firstly, the importance of sustained and meaningful engagement with our communities, so particularly our diverse communities, local leaders. I think James mentioned the importance of local leaders, community leaders, religious leaders, but also trusted healthcare professionals, GPs, and in particular, nursing staff and community pharmacists that played and continue to play a critical role in terms of our response to the challenge that COVID-19 presented. And I guess in relation to that is the second point around the importance of not just the message, but the messenger in terms of putting out the key points around prevention and around some of the control measures that we began to see perhaps emerge a little later on, because I remember, in fact, when the pandemic and the vaccine program had just been rolled out, and the message that came across was that in this country that we've got conference centres and we've got horse racing venues for vaccination hubs and centres, and yet we all know that in our diverse communities we also had black churches, synagogues, temples and mosques that in terms of their architecture were well placed to be vaccination hubs. And in fact I took my second vaccination in a community centre called the Malcolm X Centre in inner city Bristol, in an area called St Paul's, which is a very diverse area. If people know Bristol, they will know St Paul's is a very diverse area. But the messenger was so important there because you had the community leader actually at the gate of the community centre inviting people in for the vaccine. And that leads me on to the final point, which is around trust. And I'll bring this up again because I think it's so critical. Trust is often defined as truth told consistently over time. And as we've seen so vividly over the last 2+ years, it is, as I mentioned before, fast becoming a determinant of health because it's impacting upon people's choices as to what they do or what they don't do. And what we need to do, I believe, in our health systems going forward is to build or rebuild that trust with our communities.
Thanks, Habib. And actually, I'll hand straight over to Locola for the same reflection, I suppose, in a US context. Thank you.
I think this is on. Okay. I would think that one of the things we did well was really being adaptable and adaptable to things as they change, realizing that data can be slow to catch up with what's really happening, but once you receive that data, using that data to actually implement and practice new behaviors. So over time, masking mandates changed. Over time, hand washing recommendations continued to improve, the use of PPE and other things of that nature as we learn more about the epidemic, making sure that we were quick to respond. I think in saying that as well, one of the challenges, if you will, was making sure that policy and authorities kept up with the changes in terms of what data we're able to collect. Dr. Liburd mentioned the slowness of data and having, as a federal agency, we have to wait for data to come up from the state and local level, and having those authorities in place to be able to gather that data as a requirement versus a kind of optional activity in terms of making sure that at a federal level we can get the messages out. And then I think to Habib's point, the importance of the messaging that we get out and who it's coming from and making sure it's culturally sensitive and culturally responsive in terms of meeting people where they are in the messaging that we give and put out. I think CDC did a great job of being able to translate it into different languages, being able to create graphics that could really be picked up on by any level, but that need for that community engagement to make sure that went beyond just being on a website or just being a tool or resource to actually being usable and implementable, meaning that community engagement being an important factor in how we move forward and being able to actually get the work done, and that translational piece from going from like the publication to actual practicing.
Yeah, thank you so much. I think you're right. That translational piece should cut through everything we do, certainly as the observatory and as a partnership. I think that's really what we're aiming for. We have a few minutes for questions, if there are any in the audience. We'll start in the room, at the back just there.
Thank you so much. My name's Evelyn Mentz. Everyone calls me Evie. I'm an eye surgeon working in a hospital trust, which I would say has probably got the highest ethnic mix on the planet. I don't know, 67% is our workforce ethnic minority mix. And whilst we've been talking about trusted messengers for community engagement with COVID vaccine uptake, in my trust, we had to do that where I work because we were finding that a lot of the workforce didn't want to take the vaccine. And I would say for the very first time, because they asked our help, people that looked like me for the first time in the trust, they asked our help to get the message across, and we made them disaggregate the ethnic group that they'd all lumped us into, this acronym, which I hate, BAME, Black, Asian, Minority, Ethnic, which everyone says BAME houses, BAME this, BAME that. But anyway, we made them disaggregate. So, and I was just thinking, with all the different ethnic and racial groups that we have, I don't know, on our government website, for example, there are 19, and I noticed that you were presenting some of the ethnic groups in America where you have, you know, indigenous Indians and all this sort of stuff. I wondered if there's, if maybe what should happen is that when people are identifying their race, maybe they should have it as a free, because it'd be a really long list, wouldn't it, if you had to choose what your ethnic group was. But, and also one other thing I just wanted to mention is that in the UK, we work in NHS hospital trusts, and we collect that data, but trusts do collect it very badly, and there are lots of unknowns. And I think that, you know, trusts that don't collect that data should be penalized with money or something, so that people will actually, because that's the theme that seems to be happening today about data quality. Thank you.
Thanks very much. Really good question. Any people who would like to respond on the panel?
Well, the only thing I would add to what you said, because we certainly agree, and there are opportunities for further disaggregation, let's say of the Asian American, Pacific Islander, Native Hawaiian, you know, category, and there are a lot of like methodological things that have to be accounted for with that. But I think what we don't talk about so much is people who either don't want to reveal their race and ethnicity, or we had instances where people didn't know it, right? So like if you're from another country and like the US constructs around race and ethnicity aren't really known, then people, I don't really know what that is. So they didn't answer. Some people didn't answer for fear of how they believe the data could be used. Like, why do you want to know that? And what are you going to do with it? And so when, you know, we were encouraging our community health workers to explain how the data is used for public health decision making, I think, again, it comes back to trust and like, do I want to tell you or not? So that was like another factor, you know, in the data collection aspect. And then, you know, there are issues around like technology and like those states that, you know, had fully interoperable systems and those that were still having to do, I'm going to call it a paper and pencil sort of approach. So there were a lot of differences across the country that impacted the racial and ethnic data collection.
Thanks. Was there anything else from the panel on that? Yeah.
So I kind of really feel the thrust of that question. I think it's really crucially important. So for me, there are kind of two levels here. One is, how do we mandate organizations to do proper equality and diversity monitoring to make sure their data collections are full and so on. So that's one question, and I think you're right. We know that these systems work well when there are financial incentives attached to them. We do know that. So I think that's one part of it. But the other part is, how do we get meaningful data? So are the categories that we have available to us sufficient for what we need to do to monitor and address inequality? and as I implied, perhaps in some cases they're not. But nevertheless, the collection of even relatively crude data are really important to enable us to identify inequalities. But I'll come back to a point I made about community-led design, and we could think about that in terms of the research we do, as well as the data collections we do, as well as the interventions that we try and support. And I came to that thinking in part because of something that Janet Smiley said earlier, something that Priscilla Reddy said earlier, and the question that Jabir Butt asked. You know, we can actually benefit from being led by those with expertise of their circumstances, who can then identify the forms of data that might be useful for us to collect, not just in terms of ethnic categorization, but also other bits of data in order to help us work with them to design and implement interventions.
Thanks very much. Yeah, I think we have time for maybe one more question, and there's one at the front down here, Zara, if you don't mind. Thank you.
Thanks. Naomi Eisenstadt, I chair an integrated care board. It's a kind of simple question, but probably isn't simple in the answer. I'm interested for both organizations, for the RHO and for CDC, about governance. Like, what authority do you have? I'm assuming you're funded by the federal government. I'm assuming that the Race and Health Observatory is funded by the NHS, and therefore is England, not UK. You talked a lot about the actions that you want people to take. Is it the state that decides? Do you have any authority to tell people what to do, or is it all just convincing, putting the data out, making the arguments, how does the governance work?
Thanks very much. That is a complex question, but I'm going to have to press panelists for quite a quick answer, I'm afraid. Habib, do you want to start?
Great, yeah, I'll be very quick. We are funded by the NHS here in England, but we are independent, and that independence is important because people need to be confident in the objectivity of the research and the objectivity of the policy recommendations, and of course in the objectivity of the support that we provide. So yes, whilst we are focused on the priorities, the national priorities, we are independent and we are able to focus on some of the things, some of those causes of the causes, as I mentioned earlier this morning. Yeah, I mean, navigating the political jungle is part and parcel of the job, I guess.
So I'll just say quickly, as we are in a current administration that's very, very focused on equity and very supportive of it, part of the work that we're doing at CDC is really systematically looking at what we call our notices of funding opportunity. And that's how resources go out from CDC to the states. And so the notice of funding opportunity structures essentially what the recipient is to respond to. And so we are going through and systematically adding equity considerations.
So you give states money to
Yeah.
do the stuff you want them to do, and they have to convince you they can do it.
Yes.
And I would just expand, not just states, but we also give community-based organizations, local organizations funding as well. But our funding and appropriation is directly from Congress. That's where our authorities are also from. And so it's actually a hybrid model in that we are charged as the federal agency to direct public health for the United States. But in doing that, we are bound by our congressional authorities as well. And then we pass some of that down to the states, locals, and communities through those NOFOs that Leandris mentioned.
Thank you all for answering that so quickly. I think there's a juicy debate to be had there maybe later in the day. I'm going to bring things to a close now, but I just want to end by sort of stressing the importance of this bilateral partnership and the international work we do more generally. I think we've seen obviously that pandemics don't respect borders and that racism is a worldwide problem, and I think it's for us in this room in this partnership to ensure that lessons and expertise and intelligence also cross those borders as well. So thank you to the whole panel, but especially to our CDC colleagues who have travelled here today.